I am going to discuss on the topic morphology, life cycle, diagnosis, treatment of the Leishmania donovani. William Leishman, in the year 1903, the month was May, reported the parasite from the splenic smear of a soldier who died of Kala-azar or dum-dum fever in Dum-Dum. Almost simultaneously in the same year, the year was 1903, the month was July. Charles Donovan reported the same findings in the splenic smear of a patient from Madras. Hence, the name Leishmania donovani was coined. Leishmania parasite of the man are three in the landmark. That is a species complex of the Leishmania donovan that causing the Kala-azar. And the Kala-azar derived from two Indian words. One is Kala and another is jar. Kala means black and azar means sickness. That is an illness in which pigmentation of the skin turns into black. Kala also means deadly, that signifying a fatal illness. The species are Leishmania donovani that causing Kala-azar or visceral Leishmaniasis. They includes the Indian continent, especially in our country, Bihar, West Bengal, Uttar Pradesh, Assam, Tamil Nadu, and surrounding our country, such countries such as Bangladesh, Nepal, Pakistan, and Myanmar, and in certain areas of China also. Humans are the only known reservoir. The sandfly vectors are Phlebotomus argentipes in our country, whereas in China, the vectors is Phlebotomus chinensis. Another species, Leishmania infantum, that causes zoonotic visceral Leishmaniasis in the Mediterranean region, Portugal, China, Central and Middle Asia. The reservoirs are dog, foxes. Phlebotomus pernicious is the vector of the Mediterranean region, and in China, the vector is Phlebotomus chinensis. And another vector, Leishmania chegasi, that causes visceral zoonotic Leishmaniasis. And dogs and foxes are usually reservoirs, and Lurgomaya logipalpis is a vector. Leishmania tropica, that causing oriental sore, infection, limited lesion of skin and subcutaneous tissue, whereas in case of Leishmania brasiliensis, that causing spongia, infection in skin and oronasal mucosa. Leishmania donovani, that is endemic in many places in India, China, Africa, Southern Europe, South America, and Russia. In our country, it is especially common in Assam and Bengal. The Promastigote form is especially a parasite of reticuloendothelial system of the mammals. The parasite multiplies in the cells of monocytes, macrophage, neutrophil, Kupffer cells, and reticuloendothelial cells in spleen, bone marrow, and lymphoid tissue. The parasite exists in two forms, Promastigote form and Promastigote form. Promastigote form found in vertebrate body, whereas the Promastigote form that is found in sandfly vector Phlebotomus species. The Promastigote form that is also known as a flagella, no flagella, whereas the Promastigote there is a flagella. So first one, Promastigote form that resides the cells of the reticuloendothelial systems of the vertebrate host body. The parasite is 2 to 4 mm long, that is a round or oval in shape, and that is covered by trilaminar membrane. The nucleus, less than 1 mm in diameter, that stained with red with Giemsa or Leishman, situated usually middle of the cell or along the side of the cell wall. Kinetoplast that lies right angle to the nucleus, it comprises kDNA. Axoneme is a fine filament which extends from the kinetoplast towards the anterior margin of the body. It represents the root of the flagellum. A clear unstained vacuole is present along the side of the axoneme. That is a Promastigote form, that is a flagella stage. Here you see the flagella, the stage of the parasite that is only found in the gut of the Phlebotomus, that is a vector, and also found in the artificial culture. The fully developed one, that is long, slender in shape, spindle shaped structure, that's a 15 to 20 mm long and 1 to 2 mm in width. The nucleus situated centrally, kinetoplast lies transversely near the anterior end. Presence of eosinophil vacuole which lies in front of the kinetochore. Axoneme is a delicate filament which extends from the kinetoplast towards the anterior margin of the body. So there are two forms. In vertebrate body, Promastigote forms are found, whereas in sandfly, Promastigote forms are found. The Promastigotes in the cells of the reticuloendothelial system multiply by binary fission. The cells become packed up with multiplying parasites. One cell may contain 50 to 200 Promastigotes. The host cells enlarges and ultimately burst. The parasites are then liberated into the circulation and the fresh cells are invaded. The cycle is repeated and the whole reticuloendothelial system is now infected. When the vector sandfly sucks the blood of an infected person, they ingest free Promastigote forms as well as those within the monocytes and neutrophil with blood meal. Now the Promastigotes transform into Promastigotes, passed into the midgut and multiply by binary fission and become enormous in number. After 4 to 7 days, Promastigotes moves towards the foregut, developed into infective metacyclic form and crowd the pharynx and also buccal pharynx. This type of the development is known as anterior station development. When the infective sandfly bites the host again, the Promastigotes are then deposited to the host body, transform into Promastigotes and start multiplying. Sandflies are short-lived, but some infected flies may live long enough for 3 or 4 gonotropic cycles to transmit the infection. Sandflies usually take plant juices containing sugar. Such type of feeding during extrinsic incubation period enhances the production of Promastigotes. If blood is imbibed, the Promastigotes are destroyed. Now, in the vector body, 3 molecules are found on the surface of the Promastigotes: lipophosphoglycan, major glycoprotein GP63, and acid phosphatase, which are supposed to be important for protection, survival, and infectivity of the parasites. Lipophosphoglycan forms a coating, that is the glycocalyx, which protects the Promastigotes from lysis by host complement. Now the Promastigote secretes also several enzymes which protect it against host purines and oxidants and catabolized fatty acids, peptides, and amino acids. Now, what is the prevalence? Leishmaniasis is found in people in that area, especially focal area, approximately 90 countries in the tropics, subtropics, and southern Europe. The ecologic settings range from rainforests to deserts. Leishmaniasis usually is more common in rural than in urban area, but it is found in the outskirts of some cities. Climate and other environmental changes have the potential to expand the geographical range of the sandfly vectors and the areas in the world where Leishmaniasis is found. Leishmaniasis is found in people on every continent except Australia and Antarctica. In the old world, that is the Eastern Hemisphere region, Leishmaniasis is found in some parts of the Asia, the Middle East, Africa, particularly in the tropical region of the North Africa, with some cases elsewhere, and southern Europe. It is not found in the Australia or the Pacific Island. In the New World, that is the Western Hemisphere, it is found in some parts of Mexico, Central America, and South America. It is not found in Chile and Uruguay. For visceral Leishmaniasis, the estimated number of new cases per year may have been decreased to 1 lakh, but previous estimate range up to 4 lakh or more cases. The cases of Leishmaniasis evaluated in the United States reflect travel and immigration patterns. Overall infection in pupil is caused by more than 20 species of Leishmania parasite, which are spread by about 30 species of phlebotomine sandflies. Particularly species of the parasites are spread by particular sandflies. The sandfly vectors generally are the more active during twilight, evening, and night time hours. That is from dusk to dawn cycle, circadian rhythm that follow. Now, in many geographical areas where Leishmaniasis is found in people, infected people are not needed to maintain the transmission cycle of the parasite in nature. Infected animals such as rodents or dogs, along with sandflies, maintain the cycle. However, in some parts of the world, infected people are needed to maintain the cycle. This type of the transmission is called anthroponotic, that is human sandfly human. So that is anthroponotic. In areas with anthroponotic transmission, effective treatment of the individual patients can help control the spread of the parasite. Now, what is the epidemiology of the Leishmania donovani? Visceral Leishmaniasis that affect more than 100 million people worldwide, with 5 lakh new cases and more than 50,000 deaths each year. Although Leishmania donovani is only the second most prevalent Leishmania that causing visceral Leishmaniasis, it is the most dangerous form and directly fatal to the humans. Over 90% of reported cases are from India, Bangladesh, Nepal, Sudan, and Brazil. In India, it is prevalent in the eastern region, including Bihar and West Bengal, eastern Uttar Pradesh, Assam, foothills of Sikkim. It is responsible for tens of thousands of mortality among Africans in eastern and southern parts of Sudan. During epidemic, that is 1984 to 1994, death toll was high as 70% in the Sudanese population. Moreover, due to emergence of drug resistance, the prevalence is not subsiding and in fact has spread to Central Europe. For example, during the late 1990s, of cases are reported in Switzerland. Now, what are the pathogenicity? Mastigotes multiply in macrophages and other phagocytic cells of the reticuloendothelium system. The reticuloendothelial hyperplasia affects the spleen, liver, bone marrow, mucosa of the small intestine, lymph nodes, and other lymphoid tissue. So first organ, spleen, what are the macroscopic and microscopic changes? The first one, the spleen is hugely enlarged. The weight is 1 to 3 kg. The capsule of the enlarged spleen is usually thickened. The consistency of a spleen is soft. The spleen, if the spleen is cut by knife, there is no resistance. The red pulp is highly congested. The splenic tissue is prebble and there is no fibrosis. And the microscopic feature that are observed, vascular spaces are very much dilated and filled with blood. Macrophage increase in number and heavily loaded with parasites. Plasma cells are sometimes increased. The trabeculae are thin and atrophic. Then the organ liver. Liver is also enlarged and congested, and the Cooper cells are greatly increased in size and number, and their cytoplasms are packed with a mastigote. The sinusoidal capillaries are dilated and enlarged with blood. Fibrous tissues in liver are not increased. In case of the bone marrow, maturation arrest, hematopoiesis, the lifespan of the leukocyte and erythrocytes is reduced, that causing anemia. Survival time of the red blood cells is also reduced by 50%. In lymph nodes, changes are variable. LD bodies found in the lymph nodes. The intestine lesions are not feature of the Kala-azar, but the intestine ulcer are found due to secondary infection and secondary entities that may also cause the diarrhea. The skin over the entire body is dry, rough, and hurts, is often pigmented. The hair tend to be brittle and falls out, and mucocutaneous lesions may appear. Now, what is the post-Kala-azar dermal leishmaniasis, that is known as PKDL, that occurs in 20% cases of Kala-azar in Indian subcontinent, chiefly in West Bengal and Bihar. The time gap between attack of Kala-azar and appearance of the PKDL may usually be 2 years, but it may be more than 10 years, that is reported. But it may be in some cases, the PKDL, there is no history of the Kala-azar. LD bodies that are found in the skin, the subpapillary layer is edematous. Beneath this layer, granulomatous masses are seen, and varying numbers of parasites are present in the macrophages. What are the diagnosis procedure? There is a direct evidences and there are some indirect evidences also. Direct evidences by peripheral blood, by thick film method, Promastigote form, blood culture in NNN medium Promastigote form, biopsy material obtained by lymph node puncture, sternal or iliac crest puncture, or splenic puncture. Whereas the indirect evidences are two. One is a blood count parameter and another is a serum test, that is aldehyde test, positive after 3 months, antibody test, that is less reliable, and complement fixation test with WKK antigen. Now, what is Leishmanian test? A kill culture that contains 0.1 to 0.2 ml of suspension containing 6 to 10 millions of promastigotes per ml, that is injected intradermally. A positive reaction is produced in cured Kala-azar cases 6 to 8 weeks after recovery and represents a delayed hypersensitivity reaction accompanied by cell-mediated immunity. The test is positive in African Kala-azar, but not in Indian and Mediterranean Kala-azar. Now, what are the preventive measures that attack on the 5 parasites in India? There is a control measure should be treatment campaign, whereas in China and Mediterranean areas, the campaign should be directed against dogs serving as a reservoir for infection. Attacks on the vector, that against the sandfly, the transmitting agent, and personal prophylaxis, that use of mosquito net, the size 22 meshes per square inch, avoiding the ground floor for sleeping, and periodic fumigation of sleeping quarters. Now, what are the treatment procedure? Antimony compound, that's a urea, stibine, amino stiburia, neostem, sodium antimony, gluconate, etc. Sodium antimony gluconate dose at the rate of 20 mg per kg for 3 to 4 months, or synthetic non-metallic compound, pentamidine, isethionate, that are commonly used. These are the reference books: General Parasitology, T.C. Cheng; Medical Parasitology, A.K. Hati; Parasitology, K.D. Chatterjee; Medical Parasitology, Babeja and Babeja. Some of the figures that are highlighted in my presentation are captured from the Google image. Thank you, everybody.